So I don't know what is coming now, because in the program there's a sponsored lecture from Penumbra. And I don't, oh yes, here's our speaker. So, welcome.
So, first of all, thanks for invitation. And as a my disclosure, I'm an angiologist and interventional cardiologist, so probably I'm somehow biased from both specialties. And the topic of my today's talk is about Penumbra products, the novel series of guiding sheets, catheters, and aspiration catheters, the Red series and BMX guiding sheets. You have to know when you are doing stroke interventions that every millimeter and in length and every micrometer in diameter, in internal diameter, is of great importance, and it will be clear after a couple of minutes why. So we started to use Penumbra catheters maybe 3 years ago, and with starting our stroke program, and this is one of our workhorse materials for the moment. We use Penumbra Red catheters with improved technology, mainly the improvement in the distal coating, which is highly hydrophilic, and with the new construction of the catheters, which permits very flexible distal 16 centimeters or so of the catheters, and in combination with the guides, it permits to achieve, even in the very tortuous anatomies, the target occlusion vessels. The Neuron Max 088 is the old version of guiding catheter. This is a technology from the beginning of 2000s, and it has an 8 French outer diameter with 0.88 inch internal diameter, which is around 2.2 internal diameter. And this is important in general. The rule of the thumb, the materials of Penumbra, when you see some numbers after the catheter name, that means the internal diameter of the catheter. So this could orient you in inches. That could orient you about the size of the catheter you use. So as an intermediate guiding sheet, the 7 French, it was benchmark 071, which is actually it is a 6 French outer diameter catheter with 0.71 internal diameter, which permitted a combination of aspiration catheters inside it. And now there is an improvement in technology with increase in the internal diameter of guiding sheets, keeping the outer diameter at the same size, and there are significant improvement in this with the BMX81 and BMX96, which are 7 and 8 French guiding sheet with significant improvement of internal sheet diameter, which actually in case of benchmark 81, with the 7 French outer diameter, it permits to be used even through a radial approach without any hesitation of combination of other materials which could be used for thrombus aspiration during the stroke intervention. The 16 centimeter distal flexible zone is with the same coverage like Red series catheters, which make it very easy to handle into tortuous anatomy. This is extremely important, at least for our patients, because almost practically 100% of them are with arterial hypertension, with very calcified and tortuous aortic and carotid vessels. Benchmark 0.96 is 8 French outer diameter, but with extremely large internal diameter. It is combined with the dilator, which guides the sheath up to the target place, and it has the same red hydrophilic coating at the distal 11 centimeters. So the next point is so-called the science-based aspiration thrombectomy. It is, or SBAT, it is a very fancy name for what every interventionalist should know when doing aspiration thrombectomy. The first point in this concept is that you ever suck any liquid through straw, for example. The liquid is moving. For example, if you have a cup with juice and you are aspirating and sucking the juice with a straw, the driving pressure is atmospheric pressure. It is not the pressure in your mouth, but the atmospheric pressure which pushes the liquid into your mouth. And the pressure difference between atmospheric pressure and the decreased pressure in your mouth is actually the driving pressure for liquid movement. And this is the same force which is important for the suction of thrombi into the cerebral arteries. And this is why you have to keep appropriate diameter sizing regarding the vessel size of the cerebral arteries. Because if your catheter is occlusive, there is no possibility that pressure inside the artery to reach the vessel where the thrombus is located. And especially in cases with low collateral pressure or low venous pressure, there is no pressure difference which can move your thrombus to be aspirated. And this is one of the most important concepts which every interventionalist should keep in mind when he's doing aspiration. Not always the bigger is the better. Probably the most important is that bigger enough but not too much is better, because the size, the relation between the size of diameter of the vessel and the size outer diameter of your aspiration catheter should be at the ratio between 0.7 0.8, because your catheter should leave enough space for arterial pressure to go to your thrombus and to have enough pushing force that enables that the thrombus is sucked with the aspiration catheter. And this is the table which it's better to keep in mind when we talk about the aspiration thrombectomy, just to know what are the mean diameters of for example, the distal internal carotid artery or M1, M2 segments when we do thrombus aspiration, and to keep in mind again that this ratio 0.7 for your outer diameter of your aspiration catheter. And for example, if your diameter of your target vessel is around 2 millimeter, that means that the outer diameter of your aspiration catheter should not be larger than 1.5 outer diameter, just for example. And another point is that the patient, when you approach the place of occlusion with your aspiration catheter, the aspiration catheter per se decreases the gradient, and actually it increases the gradient but decreases the perfusion pressure at the target region. Sometimes if you, especially in the cases where anterior communicating artery is missing or is occluded by any reason, and when you place your aspiration catheter inside the target vessel, you just don't have enough pressure to aspirate your thrombi, and this decreases the success rate of your procedure. The next important topic is the timing. Actually, as faster you are, the better are your results. So this is the results between the correlation between the timing of procedure and the effectiveness, and there is procedural time around less than 30 minutes. When the procedure could be finished in less than 30 minutes, the effect of this procedure is best. So I will just show you one case from our practice. This is a case maybe 3 or 4 weeks ago. This 84-year female with wake-up stroke with aspect 7, and from the CT angiography, our colleagues said that the patient had occlusion at M2 segment. So this is an initial angiography, and you can see the occlusion between M2 up to even M3 segment. Very tortuous arteries with the loop at the distal internal carotid, and we had to place 2 coronary wires just to reach the initially the place of occlusion with red 68, and the catheter was introduced up to the level of the distal. I don't know if is it visible, but up to the level of the distal carotid, but unfortunately it cannot reach the target place. So the operator exchanged the red 68 with red 43, which is really very useful in this type of occlusion. And after aspiration, this is the final result with complete restoration of distal perfusion with a good venous outflow. So as a measure of good restored perfusion of the brain. So this is all for me. If you have any questions.
Are there any questions? Then my question is, yes, who is doing thrombectomies in the cerebral arteries? Stroke treatment. So for many of you, that is something that's not so familiar. Yes, so Iris, you had a question.
Would you then still recommend using a balloon guide catheter in addition to stop flow?
It depends on, I think that this is based at the moment, based mainly on the personal experience and expertise. We personally don't use it. Mainly
I routinely use it.
For this.
But
okay.
you block the flow only when...
Think about the
when you are pulling back the thrombus.
Yes,
So
it is sometimes recommended that the balloon-tipped catheter should be inflated the balloon during the aspiration and the removal of the thrombus, but personally we don't use it, mainly because of some financial reasons.
The other thing I would be interested in is because we make the whole calculation on the basis of this is fluid,
Yes.
and the fluid be able to be sucked in. But often we have some very hard thrombus, and what we now often do, and I suppose you as well, is that when you have the aspiration device put up in front of the thrombus, before you apply suction, you push it into the thrombus.
If you looked carefully on the case which I demonstrated, we made exactly this one, because in the middle we approached the thrombus with Sophia, but it was not successful. So we decided, after Red 68, we approached with 5 French Sophia, but it was not successful, and we removed it. And then we went to Red 43, and with Red 43, we go through the thrombus, just aspirating and pushing the catheter just to engage the thrombus inside, to use it like not only for aspiration, but for physical removal of the thrombus. So actually, you look carefully, obviously.
So although I know Penumbra do not want to produce a bigger sized catheters as other companies are doing, for this aspect, the larger burr makes sense. And in addition, that would already occlude the vessel so that there's no flow, meaning there would be no need anymore for a balloon guide catheter as well. So it's all, so in theory, it makes absolute sense, and in most cases, 99, whatever, 98, you'll be successful with that approach.
Yes,
But
I think.
there's still a role also to explore the bigger options, especially for those clots which are not soft clots. But it's great for
In those cases, I personally prefer to aspirate manually, just to keep not too high pressure, and to remove the system whole with opening all the Y connectors, everything. Just aspirating manually, just not to give too much pressure, not to suck the vessel, just to collapse after removal of the thrombus.
Can I have a final question? So the other thing that we do is we also remove the on-off switch that you have in between. With the new Penumbra system, I've had several cases where in the end, when I wanted to clean it, there was no flow, and there's no indication that there actually was no flow. So with the new switch, it seems that you can get blockage quite easily.
Yes, with this AI,
Others have had that.
yes.
Because you wouldn't know it. So there it makes lots of sense to be manual, because with manual you always know what's happening.
Exactly.
Thank you.
okay, so thank
you.
you very much for your
Thank you.
talk.